down to the liver. So the liver does quite a few things, as you can see from the bottom of the slide there. So it has numerous roles in metabolism, in regulation, but from a digestive standpoint, the most important thing for you to know is that it makes bile. And so the thing that bile does, or why it's important in digestion, is that bile is a fat emulsifier. And so what that means is that it's going to break larger droplets of fat up into much smaller droplets so that the lipases, the enzymes that break fat down, have access to those triglycerides. So a way to think about that, if you ever, while you're doing dishes, if you've got some fat mixed in with water there, you'll see little fat droplets that float on the top of the water. And then if you drop a little bit of soap in there, you'll notice that the fat droplet disperses and makes a bunch of much smaller droplets. That's emulsification. And so that's what bile does. The reason that's important, so bile is going to do that in the small intestine. And why that matters then is because otherwise you'd have these really big droplets of fat, and so the lipases would have a hard time getting at the triglycerides to break them down. And so by emulsifying those big fat droplets, by making them much smaller, you have much better access to those triglycerides. It's easier for the lipases to break the fats down rather than having to kind of work around the edges of a big droplet. So that's the reason that bile is going to be important from a digestive standpoint. As far as the gross anatomy goes, you can see a picture of the liver there. So as always, we're looking at a mirror image because you're looking at the patient's right and the patient's left, but you can see there that the liver has two really obvious lobes. So there's the right lobe, which is by far the largest, and then the left lobe. And the liver itself is tucked up underneath your diaphragm, most of it, because the right side is much larger. Most of it is kind of in that upper right quadrant, is primarily where you would find liver. And there are two other smaller lobes, the caudate and quadrate, and those are kind of up underneath it, so you can't see them in this view. If we look closer, so if we get a microscopic view of the liver that you can see there, so the structural and functional unit of the liver is called a lobule. And so lobules are these hexagonal shaped combinations of bile ducts, arteries, veins, and then the liver cells themselves, which are the hepatocytes. And so the hepatocytes are laid out in plates within this lobule. And so you can see here are the little hepatocytes. And so again, this lobule is hexagonal in shape. There's 6 sides to it. And so at each of the sides, you have this portal triad. And so each of the portal triads includes a vein. And so the vein is bringing back blood from the gastrointestinal tract. So it's bringing back blood from the small intestine. So that's nutrient-rich blood where we've absorbed carbohydrates, we've absorbed proteins into that blood. And so the liver then is going to filter that. But then we also have arteries that are going to bring oxygenated blood, because obviously the hepatocytes, they're going to run through a lot of ATP. They're doing a lot of work, and so they're going to need a lot of oxygen. So we've got the artery there as well. And then the last thing there is a bile duct. And so the hepatocytes, the liver cells, are going to make bile, which is then going to be transported into these bile canaliculi, which then empty into this bile duct here. And so one of the things to understand about that is actually that the blood and the bile flow in opposite directions. So the bile is actually going to flow out to this bile duct, as opposed to the blood is going to flow inward. So we're going to empty this nutrient-rich blood into, it's going to move through these little sinusoids. And so you can see there from that picture, if you look really close of where I'm mousing over, that there are pretty big gaps between the cells. So that endothelium has quite a few gaps in it. And so what that does is that really slows down the blood flow, gives those hepatocytes lots of access to the blood because we've slowed down transit time. But we also have little macrophages, little immune cells in there as well. And you can see a picture of a macrophage in there as well, so that we can attack any sort of invading pathogens that might have made their way to the liver. So that's it serves an immune function in that sense as well. So in terms of the hepatocytes, so again, what they do is, or one of the things that they do is to produce bile, which we need to break down our fats. Structurally, my little subheads on there, ER stands for endoplasmic reticulum. So they've got lots and lots of endoplasmic reticulum because they're making lots of proteins, right? They're making lots of bile. So they got lots of endoplasmic reticulum, lots of mitochondria because they use quite a bit of oxygen to manufacture all those proteins. And then we've got peroxisomes, which help to break down things like pesticides or various other toxins that you might have ingested. We're going to break those down in those hepatocytes as well. So the peroxisomes are going to be important for that function. So in addition to producing bile, you can see the other things that the liver does. So in terms of processing nutrients, one of the things that the liver can do is to store glucose as glycogen. So remember that we store glycogen in two places. You store it in the muscles and you store it in the liver. And that once glycogen is inside of the muscles, it can't come back out. The muscles don't have the enzyme that will allow us to kick it back into the blood, but the liver does. And so the liver glycogen's job is to store sugar to keep our blood glucose within normal limits. So if you have dinner at 5 o'clock, some sort of really early hour, and then you don't eat again until 10 o'clock the next morning, to keep your blood sugar from dropping too low, one of the things that you'll do is to release that you'll break down that glycogen in the liver, release it as glucose, kick it back into the bloodstream so that the brain has some glucose to run on. Another thing that we can do in the liver is to transform protein into carbohydrates. So that's called gluconeogenesis. And so if we don't have, the liver is already depleted of glycogen, well, we still need some sugar. And so one of the things that we can do then is to make new sugar from amino acid skeletons. So again, that's gluconeogenesis. So it's involved in a variety of nutrient processing sort of functions, and there are numerous other things that it does, but those are kind of the two big ones that we'll talk about from an exercise standpoint. Other things, so it can store the fat-soluble vitamins, so those include vitamins A, D, E, and K, so the ADEC vitamins, those are your fat-soluble ones, and so the liver can store those. And then it also detoxifies the blood. So one of the things that it does is helps us to get rid of ammonia, which is a byproduct of breaking down protein. So it can play a role in that as well. All right. So speaking of detoxifying the blood, so one of its most famous functions, or if people know anything about the liver, usually they know that it's involved in alcohol metabolism. So I figured it was worth discussing that a little bit. And so the liver does play a really important role in alcohol metabolism. It has lots of the enzyme alcohol dehydrogenase that helps us to metabolize ethanol. But the liver isn't the only place where we have that enzyme. So that enzyme is also found in in the gastrointestinal tract. So there's some of that in the stomach, there's some of that in the small intestine, but the vast majority of that is in the liver. So where it says first pass metabolism, that refers to the alcohol dehydrogenase that's in the stomach or in the small intestine. And so if we can break that alcohol down in the stomach before it makes it into the blood, well, then that's going to be alcohol that doesn't produce the effects that we're probably consuming it for, right? So that's first pass metabolism, is basically breaking it down before it actually gets into the bloodstream. And there are some sex differences with that. Men tend to be a little bit more effective at that than women, possibly due to different concentrations of alcohol dehydrogenase. So the basic process there, where I've got my little arrows, so alcohol dehydrogenase breaks ethanol into acetaldehyde, and then acetaldehyde is broken down by aldehyde dehydrogenase, which then becomes acetate, and then we export it from the liver at that point. So the acetate leaves the liver, and then it dumps into the circulatory system, at which point in the peripheral tissue, so in places like muscle tissue, it's going to be converted into acetyl-CoA, and then acetyl-CoA is broken down, as we'll talk about in the next chapter, is broken down in the citric acid or Krebs cycle. So things affecting how effectively we're able to metabolize alcohol. You're familiar with the basic ballpark equation, the idea that you can metabolize about 1 drink per hour, so about 7 grams of ethanol per hour. But of course that depends on numerous factors. That depends on regular consumption. that depends on body size, that depends on body fat. There's a number of different factors that play into it. But in terms of absorption and metabolism, so alcohol tends to be absorbed more quickly if there's faster gastric emptying. So if alcohol is the only thing in the stomach, as you may be aware, it moves really quickly from the stomach into the small intestine, so then it's absorbed relatively rapidly, produces a big increase in blood alcohol, and then that results in more pronounced effects. As opposed to if there's also food in the stomach, well, then you're going to slow down gastric emptying, you're going to slow down how rapidly that alcohol appears in the blood, and so then that sort of blunts the effects of the alcohol. So depends on what you're going for there. In terms of the concentration, so alcohol moves along its concentration gradient. So if the alcohol is really concentrated, it moves much more quickly into the bloodstream. So that would be if you were doing something like drinking liquor, something that is, let's say, 80 proof or 40% alcohol. So that is fairly concentrated as opposed to something that is like 4% alcohol by volume, as you get with a lot of like light beers and those kinds of things. The higher the concentration, the faster it's going to move from the small intestine into the bloodstream. And so those more concentrated alcohols then tend to produce a more rapid effect. The other thing on there is age. So as far as that goes, we tend to get less good at metabolizing alcohol with age. And so one of the reasons for that is because alcohol moves into all water-containing tissues. So it's going to move into, as you know, the brain, but it's also going to move into the musculature. It's going to move into cardiac tissue. Alcohol moves into everything, all water-containing tissue, right? And so as you get older, a couple things happen. One, the liver gets smaller, so you just have less places to metabolize the alcohol. You have fewer hepatocytes in order to metabolize it. But then two is that you're going to lose muscle mass. And so as you lose muscle mass with age, you have less water-containing tissue. And so there's less places for the alcohol to go. So we're just not as good at metabolizing it then with age. And then talked about exposure, that the more accustomed you get to, the more chronically you're exposed to alcohol, essentially the better you get at metabolizing it. That may be due to upregulation of alcoholic dehydrogenase in the liver, but that also could be due to an alteration in thyroid function. And so essentially it could change the function of the mitochondria, and so then that may play a role in speeding it up. One of the things in terms of sex differences, so I mentioned earlier as far as first pass metabolism, that men are probably better at metabolizing the alcohol before it gets into the bloodstream. But another thing is that, so if you're familiar with the idea of moderate drinking, so men drinking in moderation is no more than 2 drinks per day. For women, it's no more than 1. And so why is it half for women what it is for men? Well, one of the reasons, women tend to be smaller, but 2, women tend to get higher peak blood alcohol levels, in part because women, on average, tend to have higher body fat, right? Their body composition is a little bit different. So if your average college-age male's body fat somewhere around 15%, average college-age female body fat percent somewhere around 22. So there's less water-containing tissue for that alcohol to move into, and so that fat is resistant to that alcohol, is a way of thinking about that. And so because of that, tends to produce higher peak blood alcohol concentrations in women. All right, so a case study. So you can see my lady lifting weights there. So the case I'm giving you, or the example I'm giving you, is you're going to pretend you're a personal trainer and your client is a 44-year-old Hispanic woman. I ballparked from my picture. She is overweight and trying to get leaner before her daughter's wedding. She hasn't been feeling well for the last week, and for the past few days she's been having abdominal pain. She has a reduced appetite, and the pain has recently become more localized to her upper right quadrant. There's a hint. She's also been nauseous for the last few days and has vomited today. She noted that her urine has taken on a dark color, and now she looks like this. And so you'll notice there that the white of that that person's eyeball is fairly yellow, right? And their skin tone on the whole is fairly yellow. And so, what could be going on? Well, the answer is that she's having acute liver failure. And so the reason I set it up as someone trying to lose weight is because weight loss supplements, my what I was going to tell you is that she was taking a green tea supplement, and so green tea extract is one of the most likely to cause liver failure. There's not a ton of it that happens, but between 2006 and 2013, there were 50 incidents of acute liver failure related to weight loss supplements. So it is one of the more likely ones to cause that. Typically, somebody has to take it fairly consistently for about 1 to 3 months before they start to have adverse reactions. But tainted supplements were one of the leading causes of acute liver failure. So, for example, to put some numbers to that, the number of acute liver injuries due to tainted supplements increased from 7% of all cases of liver failure in 2004 to 20% in 2014. One particular supplement, which is advertised for weight loss, which is called Oxyelite Pro, led to 36 cases of acute liver failure in 2013 and was pulled from the market. And so jaundice, which is this sort of yellowish color, is a sign of liver failure. So what's going on there? Why does liver failure produce this yellow coloration in the skin? Why does it produce this yellow coloration in the eyes? And the answer is that jaundice is caused by an accumulation of something called bilirubin. So bilirubin is something that is formed when hemoglobin is broken down as part of the normal process of recycling old red blood cells. So as you know, red blood cells, we turn those over pretty constantly. They only live for about 3 months, oftentimes less. And so we're constantly breaking red blood cells down. And so as part of that process, one of the byproducts is this protein called bilirubin. And so normally, if your liver is functioning correctly, we're going to carry bilirubin in the bloodstream to the liver, where there we're going to bind it with bile. And so bile, as we'll talk about on, I think, the next slide, kind of has this yellowish color also because of the bilirubin. So we bind bilirubin to bile, and then the bile is going to go into the gastrointestinal tract. And so once we get it in the gastrointestinal tract, in the small intestine, it's metabolized by a bacteria called stercobilin, which gives feces their brown color. And so in the absence of bile, in the absence of bilirubin, the feces are going to take on kind of a gray or white or clay color, which is what is observed in liver failure. And so effectively, the reason that she's got this yellow coloration, the reason that she's got jaundice, is because the liver isn't functioning correctly, which means then that it's not producing enough bile, and you're not able to attach the byproduct of red blood cell breakdown to that bile to excrete it. And so instead, it ends up accumulating in the blood, and you get this sort of a yellowish color. Oh, there you go. There's your spelling. So she has jaundice, which is caused by an accumulation of bilirubin, which we normally excrete in the bile. There you go. All right, so other liver disorders. So hepatitis, so remember that an itis is an inflammation. Anything hepato deals with the liver, like we talked about hepatocytes, right? Those are liver cells. So hepatitis then is an inflammation of the liver. So often it's due to a viral infection. There's numerous causes of hepatitis. So far, 6 hepatitis-inducing viruses, which have been lettered A to F, have been identified. So hepatitis A and hepatitis E are transmitted through eating contaminated food. Those infections tend to be self-limiting, meaning if you just let the body take care of it, it's usually pretty effective at doing so. However, hepatitis B and hepatitis C, both of those are bloodborne pathogens. So if you ever have to do bloodborne pathogen training, one of the things we'll talk about is hepatitis. And so those 2 particular viruses are linked to chronic hepatitis, liver cirrhosis, and potentially cancer. Now, there are non-viral related causes to hepatitis. So that includes excessive alcohol consumption or possibly drug toxicity. So things like chronic overconsumption of acetaminophen, so Tylenol, could also cause an inflammation of the liver. Another one on there is non-alcoholic fatty liver disease, which is what's pictured there in the lower right of the slide. So you can see the normal liver there on the left, much smaller. The liver with non-alcoholic fatty liver disease there on the right. And so the white dots, or the clear parts there, those are fat droplets that have accumulated in the liver. So non-alcoholic fatty liver disease is the most common liver disease in North America, affects somewhere around 30% of the population, but 70% of those who are obese. So obesity and increased insulin resistance, which is something you'd see with like type 2 diabetes, are associated with abnormal fat metabolism and thus liver inflammation. So the main characteristic then, as you would expect based on the name, is that there's too much fat stored in the liver. It's typically asymptomatic, so you're not going to know that you have it, but it does predispose you to cirrhosis and cancer. And so the reason why that accumulation of fat matters is that if you have fat accumulating in the liver cells, well, obviously then that's going to impair their function and impair their ability to get nutrients, and ultimately can lead to death of the hepatocytes. And so we don't make new ones. They end up, at least not in that case, they end up getting replaced by scar tissue. And so then you get a liver that's less effective at doing its job. So cirrhosis then, at the bottom, is the final stage of a progressive and chronic inflammation. So cirrhosis may be due to alcohol consumption, so it may have started out as a hepatitis, may be due to non-alcoholic fatty liver disease. There are a number of different causes of it. But basically that chronic inflammation is going to result in the death of hepatocytes. Again, they're going to be replaced with scar tissue. And so that's going to progressively decrease liver function and blood flow. And so once someone gets into cirrhosis, the only way to treat that is with a transplant. And so there's my scarred liver on the left and my healthy liver on the right. All right, so let's talk about the gallbladder. So not a whole lot to say about the gallbladder. The only thing I really want you to know about it is that, or the primary thing I want you to know about it, is that it is going to store bile. So the liver is constantly producing it, but obviously we're not constantly breaking down fat in the gastrointestinal tract. Overnight when you haven't eaten anything for a long time, we don't really need that bile because there's no fat to be digested. So the gallbladder then serves as a storage site for that bile. So as I mentioned, the bile is kind of a yellow-green color, and the reason for that is because of that bilirubin. And so what bile has in it, so it's got bile salts, phospholipids, and then we'll get to recycling the bile salts when we talk about the intestine, because that happens in the end of the small intestine. So bile salts are cholesterol derivatives, so you make them from cholesterol, and so again they're going to play a really important role in the digestion and absorption of fats because they're going to play a role in that emulsification of fats. So we get rid of a lot of the products from the digestive, or that make their way into the digestive tract. Again, we're going to use bile to excrete bilirubin, but the bile salts are something that we actually are going to recycle, in that we'll reabsorb them in the ileum, the last part of the small intestine. Other things about the gallbladder, so it's about 4 inches long. Obviously depends upon your body size. So not very big, but easy, obvious if one were to do a dissection, so you can find it without too much trouble. Similar to the stomach, it has folds, so it's able to expand and contract if it needs to, and it also has a layer, it has smooth muscle that surrounds it, and so that enables it to contract, to expel bile whenever it's needed, for example, after a meal that is relatively high in fat. Let's see if I can advance this. I think I have another picture. There we go. All right, so because bile salts are cholesterol derivatives, those are the primary way that we excrete cholesterol from the body. So one of the things that can happen, though, is you can get gallstones, which you have probably heard of. And so what the basic progression there, or the basic cause of that, there are several things that can lead into that. One is consumption of too much cholesterol. And so if you've got too much cholesterol, that can play a role in terms of, basically it allows the cholesterol to crystallize and form those gallstones. Or the other thing is that you might have too few bile salts. But either way, you can get the accumulation of these gallstones, and so they can get stuck in those ducts and then can cause pretty significant pain. So again, the one thing I want you to know about the gallbladder, it stores bile. All right, let's talk about the pancreas. So the pancreas we have talked about a little bit before. We talked about it with the endocrine system. So it is both an endocrine and an exocrine gland. Remember that something that is endocrine, that's we associate that with hormonal function, which means that the products from that gland will be secreted into the blood or into the lymphatic system. So in the case of the pancreas, the hormones that it secretes are insulin, which decreases blood sugar, and then glucagon, which increases it. So two antagonistic hormones. But remember, exocrine glands are glands that secrete their products either into a body opening or onto the skin surface. So obviously in the case of the pancreas, where it's an exocrine gland, it's going to secrete its product into a body opening, in this case into the proximal aspect of the small intestine, an area of the small intestine called the duodenum. So its function then is to secrete pancreatic juice. And so pancreatic juice has at least four important characteristics. So the first one there is it's alkaline, so it's basic. So thinking back to when we talked about the stomach, so remember you've got the stomach on this picture. Pull up my arrow. So you got the stomach, and then you have the small intestine starting here. So you've got the sphincter here, and then the duodenum. So again, the proximal part of the small intestine. And so the fact that the pancreatic juice is alkaline is important because, again, the chyme leaving the stomach is going to be fairly acidic. And so to neutralize that acid and keep it from damaging the epithelium of the small intestine, the pancreatic juice will help neutralize that and help prevent that damage from occurring. So the fact that it's alkaline, the fact that it's basic, helps counteract the acidity of the chyme leaving the stomach and is important for protection of the small intestine. Other things, so pancreatic juice has proteases. Remember, those are enzymes that break down proteins. Also has amylases, break down carbohydrates, and then lipases, which break down fats. So pancreatic juice then is going to break down all three of the macronutrients that we'll need to break down. Other things there, things that cause secretion of pancreatic juice. So we talked about cholecystokinin in the first part of the chapter. So that is going to be secreted by the cells of the duodenum. And so in response to a high-fat meal, they will secrete cholecystokinin. And so CCK then travels in the bloodstream. Eventually the receptors, reaches the receptors there in the pancreas and causes the release of pancreatic juice to break down that fat. And then another hormonal control is secretin, which is also released by the intestinal cells when they're exposed to hydrochloric acid or fatty chyme. So again, because pancreatic juice is alkaline or basic, that exposure to acidic chyme is going to cause the release of secretin, which then stimulates the release of pancreatic juice to help neutralize that. So what you can see here, and I'll pull my arrow back up because it wasn't on there. Okay, so obviously the liver's up here. Here's your gallbladder, and all of this is obviously labeled. And so then there's the pancreas. But the thing I want to point out is that there's a common duct. So the gallbladder's duct here fuses with that of the pancreas. And so we're going to release both bile and pancreatic juice from this same duct there. Maybe. There we go. All right. So the small intestine. Now we're on the home stretch. So the thing to know about the small intestine, the short version is that it's the primary organ of absorption. So we absorb some things in the stomach. So for example, caffeine, alcohol, aspirin, those things get absorbed in the stomach. But from a macronutrient standpoint, we're going to absorb those things, carbohydrates, fat, and protein, in the small intestine. So there's three major subdivisions to the small intestine. The first is the duodenum, and that is the proximal aspect of the small intestine right after the stomach. Takes up about 10 inches, so it's the smallest part of the small intestine, or in terms of length anyway, the smallest part of the small intestine. And that's really, again, so that's where bile is released, that's where pancreatic juice is released. So there's a lot that goes on. We're really accelerating that chemical breakdown, that chemical digestion of food there in the duodenum. So even though it's small, there's a lot of really important stuff going on there. The next section is the jejunum. It's approximately 8 feet long, so pretty long. And then the last one there is the ileum, which is approximately 12 feet long. So between the three of them, they take up about 20 feet in terms of total length. So because the small intestine is the major organ of absorption, we want to increase its surface area, right? So it's just like we talked about with the lungs and Fick's law and all of that, that one of the things that we want to do in the lungs is to maximize surface area so that we maximize the space for gas exchange to take place. Same idea here in the small intestine in terms of absorption of macronutrients. The longer it is, then the more effectively we're going to be able to absorb those macronutrients. But in addition to its length, we also have 3 other sets of adaptations that allow us to maximize absorption. So the first one there is folds. And so you can see from the drawing that there are pretty obvious circular folds there to the small intestine. And so the reason that matters is those folds sort of spin the chyme and they slow it down. And so by slowing that chyme down and spinning it around, they expose it to some of those gastric, to pancreatic juice, so some of those digestive enzymes. So that combination of spinning and slowing it down, longer exposure time to the enzymes, and that turnover helps enhance exposure as well. Then you got the villi. So the villi you can see here, and these are these finger-like projections from the walls of the small intestine. So those also act to increase surface area. And you can also see the underlying capillary bed to those, so they have a really good circulation. And then the last one on there is the microvilli. So we're going to look at even closer up. So this is the microvilli. So what you're looking at here on the right is an individual little intestinal cell. And then obviously on the left, that's the projections that make up the microvilli. So, and further, each of those, there we go. Sorry, I messed that up. That's okay. All right. So with those little extensions there, that's further going to increase the surface area. What I messed up was the villi, microvilli in terms of, so these are the little finger-like extensions, which I should pull my arrow back up. There we go. These are the little finger-like extensions here, and then so the microvilli are the projections from the individual intestinal cells themselves. Where it says brush border, you've got enzymes on the microvilli that help finish the breakdown of things like carbohydrates. All right. So the short version is, or one of the things to know about the small intestine then, is that it has numerous adaptations to allow it to increase its surface area to maximize absorption. So it's really long, has the folds to slow down the chyme and to spin it, again, to expose it to the digestive enzymes. And then the villi, those finger-like projections, maximize surface area. And then the microvilli do that even further on a more microscopic level. You've got little projections from the individual cells themselves. So everything we do then is to try to maximize our surface area in the small intestine. All right, so some of this stuff kind of repeats with what we talked about with the stomach and gastric emptying. So in terms of regulating chyme entry, so as mentioned with gastric emptying, so if that chyme entering into the duodenum is hypertonic, so really concentrated, then that's going to slow emptying into the small intestine, as does really acidic chyme, because again, that could cause damage to the duodenum. So in terms of the digestive processes that happen in the small intestine, so you have both mechanical and chemical breakdown in the small intestine. So in terms of mechanical, so you can see again there that picture on the right that we saw last time, the segmentation, which is where you're going to compress the chyme and kind of shift it back and forth to expose it and mix it with those gastric juices or those digestive juices. And so you get that mechanical breakdown there with the physical compression of the chyme with the segmentation, and then you also, again, get that chemical digestion that's going to occur there as well. So from the small intestine to the large, eventually, there we go. All right, so subdivisions of the large intestine. So on this picture, you can see all of the small intestine through here, and then it's going to end, the ileum is going to end over here. And there's a closer up picture. There we go. So it'll end, and then the large intestine starts with the cecum. And then we move from there to, we've got the 3 parts of the colon. So you've got the ascending colon going up. So all this is in your lower right quadrant. So belly button, kind of between your belly button and your ASIS sort of area. So we go from the cecum up to the ascending colon, and then across transverse colon, down into the descending colon, and then into the rectum. So the appendix down here, you've probably heard of your appendix. So a thing to know about the appendix is that it is effectively a storehouse for the bacteria. So if you probiotics are all the rage lately. So right, probiotics are healthy bacteria. Well, where do they live? They live in your large intestine. And so they help with things like the production of vitamins, so like the B complex of vitamins, vitamin K, and so they also ferment the undigestible carbohydrates in there as well. So those are some of the things that those good bacteria do. And so the appendix acts as a storehouse, if you will, for some of those bacteria. So if you do something like take antibiotics, because you had some sort of a upper respiratory tract infection or something like that, and you take antibiotics, it's going to kill lots and lots of bacteria, including those in the large intestine. And so then we'll need to repopulate the large intestine, and so we can do that with some of the bacteria that are in the appendix. But because of its shape, the appendix can basically kind of get twisted on itself, and so you can get a blockage of the appendix, and so then that leads to appendicitis. And then if your appendix ruptures, then that's going to allow those bacteria to basically, then they're going to be inside of your abdominal cavity, and that's bad, and that can lead to a systemic infection, which can result in death. So that's bad. So appendicitis, fairly common. So one of the hallmarks of appendicitis is that essentially what happens is they typically have a low-grade fever for a few days, like around 100. They're going to lose their appetite, and then eventually it's going to go from loss of appetite to feeling nauseous and vomiting, and then they're going to have kind of this generalized pain in their lower right quadrant that eventually becomes a fairly localized pain. So it ends up being painful at what's referred to as McBurney's point, which is halfway between your belly button and your ASIS. And so if they've got localized pain there along with those other symptoms, then that means they probably got appendicitis and they should go to the hospital. So in terms of what we do in the large intestine, so we're not going to absorb things like carbohydrates, fat, and protein, but what we are going to try to do is to reclaim any fluids that we've lost. So you sort of dehydrate and compact the feces in the large intestine, and then we try to reabsorb any additional electrolytes we want to hang on to. Things like sodium and chloride are going to be reclaimed there as well. So I mentioned the bacterial flora. So those are your probiotics. Those are your good bacteria, and so there's all the things that they do. But additionally, you have some bacteria in the large intestine that, left to their own devices, could be really problematic. And so one of them is called C. difficile, or C. diff for short. And so if the other bacteria are wiped out by antibiotics, then C. diff can proliferate, and then it tends to cause an inflammation of the colon. And so it causes really hard to control diarrhea and a number of other problems. So C. diff is something that people get in the hospital sometimes, because they're on other antibiotics. They can be, and then if they're exposed to that particular bacteria, it can cause quite a few problems. So if you have lots of those healthy bacteria, that's one of the things that they can do, is sort of keep that in check. In terms of my little subpoint there about the importance of fiber, so one of the things with the large intestine is that it's going to engage in peristalsis as well. So it's going to squeeze and push the feces, from the ascending colon across the transverse and on out. And so the harder it has to squeeze, then that can stress the walls of the large intestine and result in these little diverticula, which you can see here. So these little pockets that form off of that. And so if you have a diet that is low in fiber, and so you've got really compact feces, if you will, then that means that the smooth muscle around the small intestine has to squeeze that much harder. And so then those high pressures can result in those little bubbles, if you will, off of the large intestine. And so what can happen is those can get walled off and inflamed, and so then you get a diverticulitis. And so that potentially could rupture and leak into the peritoneal cavity and could possibly be life-threatening. So where fiber comes into all of this is the higher fiber your diet, the softer those feces tend to be, and so you don't get as strong of contractions around the large intestine. So those high fiber diets then are associated with decreased incidence of diverticula and diverticulitis. So helps keep your large intestine healthy. Also speeds up transit times. So if there are things that would be carcinogens in those feces, the faster you can get them out of the body, the better. And so people that consume higher fiber diets then are less likely to develop colon cancer because the carcinogens are in the large intestine for less time. All right, and then the last thing, so a couple of different pathologies. So Crohn's disease, and you can see the picture of Crohn's disease there in the middle, but both of these are inflammatory bowel diseases. Crohn's disease in particular may affect as many as 750,000 Americans, so it's relatively prevalent. And what happens, or the actual cause, isn't all that well understood, but it appears to be similar to an autoimmune disorder. But rather than the immune system attacking the body itself, the immune system attacks those gut bacteria, the healthy bacteria that we were just talking about. And so that then tends to cause inflammation and swelling of the walls of the large intestine. And if that goes on for a long period of time, that causes ulceration and scarring. And so you can see the thickening. If I can get my mouse back, you can see the thickening of the walls of the large intestine here as that scar tissue accumulates, and you get these fissures. And so effectively then that large intestine is not as good at reabsorbing the water. And then why that becomes a problem is if you've got a bunch of water in your large intestine, of course, then that produces diarrhea. And so that's problematic. So because of that damage to the lining of the large intestine, we can't absorb water, and then it tends to cause pretty chronic diarrhea, as well as abdominal cramps, pain, pretty consistent feeling of needing to use the restroom, and then because of those things, loss of appetite, weight loss, and fatigue, because people then stop eating, because when they eat, then they get sick. So it typically affects the ileum, so that last part of the small intestine, or the colon, any part of it, but it could be anywhere in the gastrointestinal tract, but most commonly it's in somewhere in the large intestine. So typical treatments for that include things like immune suppressors, antibiotics, and antidiarrheals. One of the real dangers with this is that you can get what's called a fistula, which is a passage between, so where these fissures are, you get a passage that forms between the large intestine and nearby organs, so things like the bladder. And so then you're going to get bacterial movement into the bladder, and so as you can imagine, that becomes really problematic and could lead to a systematic infection, especially if you get leakage of that bacteria into that peritoneal cavity, so inside of the abdominal cavity. And then the last one on there is ulcerative colitis, and so you can see that one there on the right. So it's pretty similar to Crohn's in that it's an inflammatory bowel disease, but it's limited to the colon, as opposed to, again, Crohn's can be anywhere, although most commonly in the colon. So Crohn's can also affect all layers of the bowel wall, while ulcerative colitis only affects the lining, but the symptoms are similar. So with ulcerative colitis includes diarrhea, abdominal pain, and potentially blood in the stool. With ulcerative colitis, affects men and women equally, but it's typically diagnosed in one's 30s, and the treatments for the two are basically the same. And so we'll end on a couple really gross pictures. So there is, well, this one's not too gross. So this is, that's a healthy large intestine. So that's what that looks like. And so you can see, good blood supply here, and it's able to absorb fluid pretty easily. And then if you've got one with ulcerative colitis, actually I think this one's Crohn's disease, but you can see, yeah, it's Crohn's. But you can see the damage there and how different that looks than this one. And so with all of that scarring and inflammation, how it then becomes ineffective at reabsorbing the water, which then leads to those symptoms of cramping and diarrhea, which are so problematic. All right, so that's it for the GI tract. So next time we'll be on to metabolism, and that'll be our last chapter that we have to cover.